Okay, as we begin our review of orthopedics, we're going to begin with disorders that affect children. We're going to begin with those that are in the hip. Opinion number 1 says in the newborn nursery, it is noted that a child has uneven gluteal folds. Physical examination of the hips reveals that one of them can be easily dislocated posteriorly with a jerk and a click and return to normal position with a snapping. The family is concerned because a previous child had the same problem. This is developmental dysplasia of the hip, that at one time used to be called congenital dislocation of the hip. The name now is developmental dysplasia of the hip. It may be obvious on physical exam. If not, a sonogram can produce a diagnosis if needed. And we treat these with abduction, AB. Abduction splinting with a public harness. I'm going to repeat all this, by the way. Opinion number 2 says a 6-year-old boy has insidious development of limping with decreased hip motion. He complains occasionally of knee pain on that side. He walks into the office with an antalgic gait, and passive motion of the hip is guarded. In this age group, the condition is probably leg Perthes disease, which is a vascular necrosis of a capital femoral epiphysis. We can diagnose this one with an X-ray. The treatment is a little controversial as to how exactly is best to contain that femoral head in place. I should use this opportunity to remind you that in children, pathology of the hip may present with hip pain, but may also present with knee pain. And so any one of these vignettes that has hip pathology, the description may be pain in the knee or pain in the hip. Vignette number 3, a 13-year-old obese boy complains of pain in the groin. It could be the knee. And is noted by the family to be limping. He sits in the office with the sole of the foot on the affected side, pointing toward the other foot. Physical examination is normal for the knee, but shows limited hip motion. As the hip is flexed, the leg goes into external rotation and cannot be rotated internally. In this age group, this particular description, this is an orthopedic emergency called a slipped capital femoral epiphysis. X-rays will make the diagnosis, and the orthopedic surgeons will pin that femoral head in place as an emergency. The longer it stays out, the more likely it is to die. And we move to the 4th vignette. A little toddler has had the flu for several days, but he was walking around fine until about 2 days ago. He now absolutely refuses to move one of his legs. He is in pain, holds the leg with the hip flexed in slight abduction and external rotation, and you cannot examine that hip. He will not let you move it. He has elevated sedimentation rate. This is another orthopedic emergency, a septic hip. Under general anesthesia, the hip is aspirated to confirm the diagnosis, and then open arthrotomy is performed for drainage. Let me repeat these conditions that affect the hip in children, because the shortcut for you to recognize right away what it is happens to be the age. So let me repeat this. We're going to cut away from my face and go to screens that have the appropriate words. So if you have disorders of the hip in children, if it happens at birth, you think of developmental dysplasia of the hip, and you do a sonogram for diagnosis, and you treat it with a public harness. But if the child that has something wrong with a hip is a toddler, a little toddler who has had a febrile illness for a day or two, then you think of a septic hip, and you aspirate and drain, and this is an emergency. But on the other hand, if the child that has something wrong with the hip is around the age of 6 years, this is probably a vascular necrosis. And this is the one where the treatment is somewhat unclear as to what is the best way to proceed. And finally, if the disorder of the hip is at around the age of 13, a male who's either chubby or tall and lanky, you think of slipped capital femoral epiphysis, and this is a surgical emergency. Here is a picture of a child that has the leg Perthes disease. So typically this would have been a child around the age of 6 complaining of pain in the hip. And so with that description plus the picture, you should be able to make the diagnosis. We now have a few illustrations of some of the fractures in children that we have talked about. This first one you're looking at is a supracondylar fracture of the humerus. You can recognize from the shape of the image that this is indeed the forearm of a child. And if you see this particular picture on the exam, you know that the important feature about this vignette is that the child is at high risk for vascular compromise in the forearm. The next picture shows you a pretty typical toddler's fracture. This one happens to be on the tibia, and this is very often the way fractures look in children, without a lot of displacement and simply a little line of a fracture there. And the next three give you a little more detail about fractures that involve the growth plate. This, in fact, uses a classification called the Salter-Harris that I did not go over on my comments apropos of the vignettes. But I'm going to show them to you simply so that you recognize the presence of a fracture that involves the growth plate. In that classification, that Salter-Harris, which goes from 1 through 5, the closer you are to 5, the more difficult the problem is. So you have a relatively simple fracture here that involves a growth plate. You have one that looks significantly worse, and here is another one that also is a heavily involved damage to the growth plate. We're now on vignette number 5. A child with a febrile illness but no history of trauma has persistent, severe, localized pain in a bone. You think with this description of acute hematogenous osteomyelitis. And rather than ordering x-rays, you're better off using bone scans, because typically the x-ray doesn't show anything wrong right away. It will in a couple of weeks. But right now, bone scan is more likely to be abnormal, and then you treat the child with antibiotics. We move then to vignettes 6 and 7. A 2-year-old child is brought in by concerned parents because he's bow-legged. In vignette number 7, a 5-year-old child is brought in by concerned parents because he's knock-kneed. Neither of these children has anything wrong. Because in fact, at certain ages, there are certain positions that look abnormal but are actually normal for that age. Genovarum, which is a fancy name for bow leg, is normal up to the age of 3. And genovalgus, which is knock-kneed, is normal between the ages of 4 and 8. So neither of these children require therapy. Now, if there was genovarum, bow legs, beyond the age of 3, then you may have a problem, and that would likely be blount disease, a disturbance of the medial proximal tibial growth plate, for which surgery can be done. Now we'll move to vignette number 8. A 14-year-old boy says he injured his knee while playing football. Although there is no swelling of the knee joint, he complains of persistent pain right over the tibial tubercle, which is aggravated by contraction of the quadriceps. Physical examination shows localized tenderness right over the tibial tubercle. Let me point out a few things that this vignette exemplifies. As a rule, when something important is happening to the knee joint, something bad, there is swelling of the knee. So when you're reading an exam question, there is some complaint referable to the knee, but there's not a swollen knee. Probably there is no problem with the knee joint, which is in fact the case here. Because once you examine the patient, you realize that it is on the tibial tubercle where you have the pathology. And this is another disease with a fancy name, Osgood-Schlatter disease, which is osteochondrosis. of the tibial tubercle. This is usually treated with immobilization of the knee in an extension or cylinder cast for 4 to 6 weeks. Now we move to vignette number 9. A baby is born with both feet turned inward. Physical examination shows that there is plantar flexion of the ankle, inversion of the foot, adduction of the forefoot, and internal rotation of the tibia. If you see my hands here, and they are demonstrating what the child's feet look like, they look like this. If this child were walking, he would be walking on the dorsum of the foot. This is a common problem. The name is club foot for the lay people. The fancy name is Talipes echinovarus. This is treated typically with serial plaster cast, started in the neonatal period. The sequence of correction starts with the adducted forefoot, and then the hindfoot varus, and then the equinus. So we go from the more distal to the more proximal of the lesion. About half the patients respond completely, need no surgery. Those who require surgery are operated on after the age of 6 or 8 months, but before the age of 1 or 2, so they can be ready to walk when kids are normally ready to walk. The next vignette has to do with scoliosis, vignette number 10. A 12-year-old girl is referred by the school nurse because of potential scoliosis. The thoracic spine is curved toward the right, and when the girl bends forward, a hump is noted over her right thorax. The patient has not yet started to menstruate. Let me give you a little summary here about scoliosis. It is, in reality, a pretty complex problem for which many orthopedic surgeons refer patients to those with specialized training. But the essentials are here. This is a problem that happens to little girls rather than boys. This is a problem that is most noticeable during the years of the growth spurt. The earliest physical finding is the elevation of the right hemithorax when you're looking from behind and the girl is bent over. Eventually, the thoracic spine will be curved towards the right rather than the left. And the progression of the disease tends to stop once skeletal maturity has been reached, which happens usually about 2 years after the onset of menses. So we have here clearly a little girl who has the problem, and the problem is going to continue to get worse. So she needs intervention. The intervention typically begins with bracing, and it may go on to other means like casting or perhaps even surgical intervention. This is not only a cosmetic problem. There could be pulmonary function anomalies if the problem is not corrected. And with that, we move to fractures, still talking about children. Now, fractures in children are usually less of a problem than they are in adults. Kids tend, first of all, not to break bones. Where an adult would break a bone, a kid doesn't. Where a kid breaks a bone, it has a green stick fracture, which is less of a problem. When they actually have a clean break, they heal a lot faster than adults, and they have a tremendous capacity for remodeling of fractures. Now, this remodeling doesn't apply to rotational deformity, but all other types of deformity. But there are some bad news in fractures of children. If a fracture in a child involves the growth plate, that can be a problem. And there is a particular fracture in children, supracondylar fracture of the humerus, that has a very high incidence of neurovascular compromise on the forearm. So let's go through some of the vignettes. Vignette number 11, a 4-year-old falls down the stairs and fractures his humerus. He's placed in a cast at the nearby dock in the box, which means at a little emergency clinic type of place. And he's seen by his regular pediatrician 2 days later. At that time, he seems to be doing fine, but AP and lateral X-ray show significant angulation of a broken bone. Well, nothing needs to be done. This is a 4-year-old kid. Leave him the way he is on that cast. Once the cast is removed and the kid keeps on growing, the kid will remodel that bone. So You don't need to redo it. You don't need to break it again. You don't need to take him to the operating room. Nothing. Vignette number 12, an 8-year-old boy falls on his right hand with the arm extended and he breaks his elbow by hyperextension. X-rays show a supracondylar fracture of the humerus. The distal fragment is displaced posteriorly. Now this is a bad one. In fact, I think we can show you a picture right now of this supracondylar fracture of the humerus. This supracondylar fracture of the humerus, the problem is the probability of vascular compromise to the forearm. So look in the answers for the one where you have compulsive checking of the pulses or Doppler studies or whatever, because this is the problem with this particular type of injury. Now the next two have to do with involvement of the growth plate. I'm going to read the two. I'm going to give you some guidelines. There'll be some pictures then afterwards to see some of these. A child sustains a fracture of a long bone involving the epiphysis and growth plate. The epiphysis and growth plate are laterally displaced from the metaphysis, but they are in one piece. That is to say, the fracture does not cross the epiphysis or growth plate and does not involve the joint. And in contrast with that, a child sustains a fracture of a long bone that extends through the joint, the epiphysis, the growth plate, and a piece of a metaphysis. Now, that is bad news. Let me contrast these two. And the first one, the first of the two vignettes, even though there is involvement of the growth plate itself is not in two pieces. This can be manipulated back into place, put in a cast. But in the second example, the growth plate is in two pieces. This needs to be very precisely aligned with open reduction and internal fixation.